Okay, ladies and gentlemen, welcome back to today's discussion. We'll be having three in one discussions today, but I don't know if there's anyone else online. I can't see anybody. Okay, I just see one person. I think that is enough. I know by tomorrow they'll come and watch. Okay, okay. I know tomorrow by tomorrow they'll watch the rest. Uh, I've noticed that the following day, quite huge number of people join. They watch the session. So that's okay. Okay, so when we are looking today's discussion is going to be about peptic ulcer disease. So we are looking at peptic ulcer disease. We are looking at the duodenum. Okay, we are looking at the stomach itself. So in order to talk about the stomach and the duodenum, we need to look at the anatomy of the stomach. We need to look at blood supply to the stomach. So with the blood supply of the stomach, blood supply to the stomach, we are looking at the abdominal aorta. So the abdominal aorta is the main vessel that supplies the stomach with blood. Okay, with blood supply. So we have on the abdominal aorta, there's a celiac trunk. That is where almost all the arteries branch off from to supply the stomach. So we have the celiac trunk. So from the celiac trunk, we have the celiac artery, which supplies it goes all the way, supplies some part of the lesser omentum, and then it branch off to the top there to supply some part of the fondal part of the stomach, and then some one third portion of the esophagus, and then the splenic artery also joins with the celiac artery to supply um, some portion of uh, the fondal part, but a little towards the middle part, okay, of closer to the fondal part, and then supplies the spleen as well. And then with the some part of the greater omentum at the back, okay, we have the if the stomach is like this, so we're looking at the left. So left gastroepiploic artery, that one supplies the left part of the fondal, sorry, the left part of the greater omentum. Okay, and then we have the when you move a little down, you meet the right gastroepiploic artery. So that artery supplies the uh, towards it supplies some part of the greater omentum. Sorry, not the greater curvature of the stomach, and then some part of the antral part of the stomach. So that is basically how the blood supply is. And looking at, we are doing PUD, and then we are doing how do you call it? GERD, okay, and then and some other stuffs like that. So we have to also look at the esophagus. The way the esophagus is positioned, it is positioned in a way that um, any least irritation or least erosion, you might misdiagnose the person um, of another condition. That is, if you are not clinically skilled enough, you might miss a diagnosis. So the upper part of the esophagus, for some strange reason, is a skeletal muscle. Is because one has to, you once you put the food there, it has to, I don't know, you need some skeletal muscle to push the food down there. Uh-huh. And then when you move to one third, the two third portion, the middle part of the esophagus is mixed with both skeletal muscle and then smooth muscle. Okay. And then when you move to the lower one third, the last part of the esophagus, that is only made of smooth muscles. Uh-huh. So once it crosses the second part, the third part, I don't know, that part, nothing, it goes by itself. The food has to go by itself. Nothing will have to squeeze for the food to go. Uh-huh. And it's made of stratified squamous epithelial tissue as well. So that is about the esophagus. It's also uh 25 centimeters long. It's usually about 25 centimeters long in almost all adults. And so when you are examining a patient, you have to keep all these things in mind. That is why most of the times when they are passing NG2, they tell you to measure from here to here, and then that thing, it gives you a clue that you are dealing with a 25 centimeter. So if you pass your NG tube and still it is not getting there, then or you just passed a little halfway through and it is already there, then you know that you are probably not in the stomach, because from this part to that part is 25 centimeters long. Hey, I don't know if you can you can hear me. Okay, so when you're looking at we are looking at peptic ulcer disease, we are not looking at only H. pylori. Most of the times we look at only H. pylori, but H. pylori actually is part of one cause of a peptic ulcer disease. When you're looking at peptic ulcer disease, you're looking at the duodenal ulcer and you're looking at the gastric ulcer. Sorry, we learned all these things in university, but I'm just trying to do a refresher course for like to have a clue. Okay, we did all those things in school, but it's always good to remind ourselves about starting. That's why I started with the anatomy of the stomach and all those things, so that we can always revise. So where was I? Uh, so when you're looking at peptic ulcer disease, we are looking at lots of causes. So there can be, so it's not only the H. pylori we are looking at other causes like NSAIDs, okay, NSAIDs induced peptic ulcer disease. Okay, so if you have your STG book with you, let's start. So they are saying peptic ulcer disease may be duodenal or gastric ulcer. And if you've been in school, you know that when those with gastric ulcer, they complain when food falls into their stomach. And those with duodenal ulcer, they complain when they are hungry. They have the abdominal pain when they are hungry. However, they tend to eat a lot so that they don't feel the pain. So duodenal ulcer people in general, most of them look fat than those with gastric ulcer. Sorry, those with duodenal ulcer, they tend to grow bigger because they eat almost all the time. And then those with gastric ulcer, because they feel pain when they eat, they tend not to eat at all. So if you get a case like that, it's always good to do urine IE. Well, if you do urine IE, you will see a ketone body in the urine. It doesn't mean the person is diabetic. It just means that they are not eating, so their body is switching to is becoming is switching to ketosis. How do you call it? Is it glycogenolysis? Eh, no, gluconeogenesis. Sorry. So the body is using other stuffs instead of glucose, and so when they use protein or something, the byproduct becomes ketone bodies. And then with the ketone bodies too, we have three types of ketone bodies. Uh, we have the acetone, we have the acetoacetate, and then we have beta hydrobutyrate. This thing can actually come in the exams. That's why I'm maybe so you may not know what will happen. You can get there, they say states the three ketone bodies, and then you may be lucky if you probably heard this thing I'm saying, maybe you'll be able to write it there. And then, so the ketone bodies, we have acetone, acetoacetate, and then beta hydrobutyrate. So there are three ketone bodies. So those of you who want to diagnose diabetes and all those things, it's usually is the beta hydrobutyrate that is of clinical concern when you're doing when you I think it's one of them, yeah, but I think it's the beta hydrobutyrate that is the cause of concern when you do the urine dipstick for the diabetics. That's okay. So with the H. pylori, we have so duodenal ulcers. They say duodenal ulcers are more common they are more common in adults. Okay, they are more common in younger adults, and then um, and then the gastric ulcers are they usually occur after middle age. So when you say middle age, you're looking at someone between the age of 45 and above, like 40 something, 50 something. They are all middle age. Elderly starts from age, I think, is it 65 or 60? I think it's 65 going. And those are elderly. So middle age. So middle age people, when they complain of ulcer, is likely to be a gastric ulcer. And then when the young people present with ulcer, it's highly possible that is a duodenal ulcer. Why should you care about ulcer? Because you should care, especially when the ulcer is coming with it's coming with some level of anemia. The anemia is quite chronic. You have to care because for all you may know, it might be gastric cancer. So when the person has peptic ulcer, we know sometimes their stool can be black or whatever, whatever. But if it is still persistent, you need to probe in further. So in this discussion, we'll find out what to do when you get a case like that. Uh-huh. Okay. They say so. It says peptic ulcer may lead to a life-threatening complication such as bleeding, perforation, and gastric outlet obstruction. That one is also a very important case to note. Okay, so what are the causes of peptic ulcer disease? We have Helicobacter pylori infection, and that is what most of us we treat. When PUD people come, we will do the H. pylori test, either blood or stool, to find out if the person has H. pylori. However, H. pylori is not the only organism that causes peptic ulcer disease. So we have excessive secretion of gastric acid. Maybe for your own, I don't know how God created you. For some strange reason, your body is producing more gastric acid than normal through the gastric pits. Okay, your body is producing excessive of gastric acid more than normal. So with that one, um, you tend to have erosion of the lining of the stomach. Talking of the lining of the stomach, let me touch on this one very quick. The reason why we don't give NSAIDs or we don't give how do you even call these things? Yeah, NSAIDs, brufen. The reason why brufen and diclofenac is contraindicated in peptic ulcer disease is because the stomach has two main important lining. That is the COX. Okay, we have the cyclooxygenase 1 and then cyclooxygenase 2. The cyclooxygenase 1 helps in protecting the lining of the stomach, and the cyclooxygenase 2 does not have any protective function of the stomach. However, when when the person is in pain and you take brufen and diclofenac, all those things they are after inflammatory mediators such as mast cells, leukotriene, and prostaglandins. However, if you take this, how do you call it, NSAIDs, it is going to, in an attempt to inhibit COX-2, okay, it's affecting COX-1. And the COX-1 is the one that protects the lining of the stomach. So in an attempt to protect the cyclooxygenase 1, it will affect the cyclooxygenase 1. In an attempt to inhibit cyclooxygenase 2, okay, it ends up affecting cyclooxygenase 1, and that worsens the ulcer. Okay. So it's always advisable to maybe you can stick to a selective COX-2 inhibitor. That is there's a trade name called Celebrix or Celecoxib. You can get those ones. The dose is 200 milligram BD. Okay, so let's go on. So it's not only H. pylori that causes ulcer. Another cause of ulcer is excessive gastric acid secretion. And then you have inadequate protection of the lining of the stomach and inadequate protection of the lining of the stomach and the duodenum against digestion by acid and pepsin. So maybe for some strange reason, I've already said it already. For some strange reason, your stomach is producing so much acid, and so there is no adequate protection of the lining of the stomach. There is no adequate protection for cyclooxygenase 1. Okay, just like I've explained it. If you don't, if you are facing some, if you need some elaboration, you can comment in the comment section, and then I can I can repeat myself again, okay, so that the learning process will be quite interesting. Okay, so we have the drugs, medicines such as non-steroidal anti-inflammatory drugs, such as and the NSAIDs, like I have just mentioned their names: aceclofenac, diclofenac, ibuprofen, and all those drugs. They are actually after inflammatory cells, like the mast cells, the leukotrienes, and then the prostaglandins. Okay. Uh-huh. So what are the symptoms? Do they normally patients come with abdominal pain? That's episodic abdominal pain, usually aggravated by certain specific food. Usually, we all know that spicy food like Indomie and all those things, they are the ones that causes they aggravate the symptoms. So when someone comes with peptic ulcer disease, we are looking at our target is epigastric region. Okay, so you ask where the pain is, you palpate, and then epigastric region. Sometimes too, because the stomach is more to the left, you are looking at right hypochondriac region. Okay, so when you are palpating the abdomen, you are looking out for tenderness, you are looking out for masses, because it could be, if it is gastric mass, it might be difficult to palpate, but try, you might be lucky enough to pick something. Uh-huh. And then they also tell you that they have abdominal discomfort or a dull aching of the stomach. It's also possible. Or sometimes the pain can be very severe, severe abdominal pain. So, okay. Occasionally, too, you see, I told you that the esophagus is 25 centimeters, but there are some people whose own is shorter or longer than that 25 centimeters. And the shorter the esophagus, the more the stomach will be high up. And the longer the esophagus, the more the stomach will be down, down, down. So you realize that some people, they'll tell you that they have they feel pain in their stomach. But when you palpate, it is around their periumbilical region. Their periumbilical region. But actually, to them too, that is their stomach, especially in children. So you realize that you do PUD test and it is true, it's positive. You put them on their medication and they are responding well. But they didn't tell you here. They told you it's just on top of their umbilicus. And them too, that is where their stomach is. So you just have to accept them like that. So occasionally, some of them to have some retrosternal. Occasionally, it is also high up behind the sternum. Okay, so occasionally they feel some retrosternal pain. When you say retrosternal pain, this is your sternum. This one, this is your sternum. Okay, sometimes you feel the pain behind the sternum, from the sternum from here to here. This is your angle of Lewis. Okay, angle of Lewis in here. So sometimes the sternum, it moves from here up to the down, up to the xiphoid process. Okay, the xiphoid process, xiphisternum. I don't know how to put it. I can't show you my six packs because it's very important. So from this part, angle of Lewis to the xiphoid process is your sternum. So the pain can be anywhere around this region because your esophagus is actually behind all these structures. Okay. The next point is, in duodenal ulcer, pain typically comes on when the patient is hungry and the patients may wake the patient up in the middle of the night. And in gastric ulcer, it is typically worsened by food and may be relieved by vomiting. Okay. And then sometimes too, duodenal ulcer is relieved by alkalis and some other things. So if you give the patient, how do you call it? magnesium trisilicate and all those things, sometimes the pain goes away. The abdominal pain, it goes away. Okay. So if you have the STG, I'm scrolling down. I'm using my laptop. So in children, the pain is periumbilical. I think I've already said that. In children, the pain is on periumbilical. So what are some of the signs? So there may be no abdominal signs. Hey, there may be no abdominal signs. Okay, and then there's usually weight loss, usually in patients with gastric ulcer, and then there's weight gain usually in patients with duodenal ulcer. Sometimes there's epigastric tenderness, and then hypochondriac tenderness, or umbilical region or para-umbilical region. So sometimes I think MDC they can set some question for you. They can say which part of the stomach are you likely to elicit pain when it comes to peptic ulcer region. And so you are looking at epigastric region, right, right hypochondriac region, because that is where the antral part and then the duodenal part is. The duodenum, okay, that's where it is. So you're looking at epigastric region, you're looking at right hypochondriac region, and you're looking at periumbilical region. Okay, let me stand up and see if I can explain. Okay, so you're looking at epigastric region, you're looking at right hypochondriac region. Okay, here, right hypochondriac region, and you're looking at periumbilical region. This is my umbilicus, periumbilical region. Okay, so when you have a patient like that, you can do those. Those are the main regions. Yeah. I'm not going to take off my top because YouTube is it can go viral and then you know. With what you have to do is you do your HB, you check the HB because the patient might be bleeding. Okay, so you check the HB and then you do your H. pylori. We have the stool and then the blood. You can choose any of them. And then we have the oesophagogastrodiodinography, duodenoscopy. Yeah, it's the same as the endoscopy. But in Ghana here, actually, that is the gold standard. Okay, they pass the tube and then they check, they look inside the stomach, and then if the patient has an ulcer, then they get to know. But then if your patient cannot afford, you don't do gold standard. Just do your H. pylori. If it comes positive, you just treat. I mean, if this is not a drug that kills, it's not like chemotherapy or anything. So if you do it and it's positive, just treat. You won't cause any trouble. Okay. So sometimes you have to do a stool examination to exclude intestinal parasites. It's very important. But on a normal day, if any H. pylori patient comes to you, what are some of the indirect questions you would want to ask? I would want to see some of the answers in the comment section. So someone comes and you're suspecting H. pylori, you are suspecting peptic ulcer disease. What are some of the questions you are likely to, what questions would you like to ask? Okay, me, what I would like to ask is whether their stools are dark colored stools, whether they feel nausea, and anything abdomen there. If it's a woman, you have to exclude pregnancy. So you have to know the LMP. For all you know, it can be something. And then if it's a middle aged, well, there are many causes. Um, you can also ask if they've been having recurrent anemias. So you are looking at with that one, you're looking at bleeding peptic ulcer, and you are trying to rule out gastric malignancies. Okay. And then what again? Yeah, you can ask if the patient has been having uh not a either dark colored stools or bright red stools. It's also important. Okay. So what are the non-pharmacological treatments? Hey, with a treatment plan, we have to relieve pain. That's dyspepsia. Dyspepsia is feeling abdominal discomfort in your stomach. Okay, so you have to relieve pain and to eradicate peptic ulcer, H. pylori. So to relieve pain in peptic ulcer, you cannot use NSAIDs, you cannot use diclofenac, you cannot use aceclofenac, you cannot use brufen. So you use either the opioids. Okay, someone said, do you feel pain when you eat? Okay, yeah. So this is a very good question. So you can ask the patients whether they feel pain when they eat, and that clearly tells you that it is a gastric ulcer. Okay, so clearly those are some of the undiagnosed questions. Okay, so with the management of PUD, when they are in pain, you cannot use the NSAIDs. You cannot use diclofenac, ibuprofen, or aceclofenac. What you can do, you can either use your paracetamol or you use your opioids. That's tramadol or morphine or whatever it is. But I mean, morphine is too much. But I mean, if that's the only thing available and the patient is really, really in pain, then that should be something to consider. So you are relieving pain. So you can use with the pain, you can also give your antacids. Okay, you can give your antacid. You can do magnesium trisilicates. You can either do what do you call it? Any of the antacids, any of them, milk of magnesia or anything. You can just give any of the alkalis, and it should be able to work. Okay, so avoid the person has to avoid taking alcohol, avoid tobacco intake, avoid food that aggravates the stomach pain, and then um, to avoid stress. So we have stress gastritis. I don't know if you've come across. Apart from this uremic gastritis, I know we have stress gastritis, and then um, and then the person has to opt for surgical cases in case the case is a chronic one. When it comes to when it perforates, then it's a surgical case. So let's look at some of the pharmacological treatment. What drugs do you need to to manage dyspepsia? So with the STG, they are objective rating A. The first one is magnesium trisilicate. So that should be your first option, or aluminum hydroxide. Also, you can use omeprazole. Omeprazole, isomeprazole, they all come with the same dose. Omeprazole is 20 milligram, isomeprazole 20 milligram, omeprazole IV 40 milligram, isomeprazole 40 milligram. But some people do 80 milligram start 40 BD. I mean, you can also do the same thing if you want. Okay. Can someone tell me what prolonged 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 omeprazole. What when you take omeprazole for a long time, what is the side effects you are likely to experience? Okay, so you can use omeprazole, you can use pantoprazole. So for the management of dyspepsia, you can do magnesium trisilicates, aluminum hydroxide, omeprazole, isomeprazole, pantoprazole. Pantoprazole too is 20 to 40 milligram daily. Okay. So when it comes to bleeding peptic ulcer disease, um, there's indication that's a clear indication for surgery, and so you can put a patient on IV isomeprazole 40 milligram daily, or IV omeprazole 40 milligram. So let's look at H. pylori eradication. This question, this chart, if you have the STG book, scroll to that, flip to that page. Is table 1 to table 5. H. pylori eradication therapy is very important. So with H. pylori eradication therapy, we are looking at one PPI, that's proton pump inhibitor. You take one PPI and you take one, two antibiotics. So with the two antibiotics, you either do the penicillins together with the how do you call it, the azoles, the metronidazole, and the rest, or you can do the clarithromycin. So with a combination therapy, you can either use amoxicillin, clarithromycin, and hey, okay, I'm coming in just a moment. Okay, so if you are doing isomeprazole, you can do isomeprazole and then amoxicillin 1 gram BD and then clarithromycin, or you can do isomeprazole and then you do clarithromycin and then metronidazole, or you can do omeprazole and then you do amoxicillin and then you do clarithromycin. I think these are the combinations I prefer. I usually prefer the old one, the one. So I use omeprazole so that I don't forget when it comes to MDC, so that you don't forget. So you do omeprazole, you do metronidazole, and then you do amoxicillin. But if you don't like that combination, you can take the metronidazole out and replace it with clarithromycin. So you can do omeprazole, um, amoxicillin, and then clarithromycin. So the combination need a bit, so you have to figure out which one you want. Me, I want something I can easily remember. So you can choose any of them that you want. And so you have to avoid treatment regimen including penicillin in patients who have penicillin allergy. So talking of that, which patients have penicillin allergy? There's a genetic condition that um, uh, makes patients prone to anaphylaxis when they take penicillin. You can write the condition in the comment section. So we are done with H. pylori. Any questions so far? Any questions so far with H. pylori? So with the STG, they are saying that we should treat it for with the H. pylori eradication. We are looking at 10 to 14 days treatment plan. 10 to 14 days treatment plan. So any of them, you can either do amoxicillin, omeprazole, clarithromycin, or metronidazole, amoxicillin, omeprazole. Or you can choose um, any of the regimen. So I'm coming. Just give me some few minutes, and then we'll come and treat the gastroesophageal reflux disease. Okay. Okay. So GERD, gastroesophageal reflux disease. Gastroesophageal reflux disease. Last time I told everyone about blood, venous supply, no, not venous, nerve supply to the gut, and it's been supplied by the vagus nerve, okay, the vagal nerve, cranial nerve 10, and that is usually parasympathetic in nature, okay. So the GERD is simply the backflow of gastric contents, okay. um They are saying that gastroesophageal reflux disease is caused by the backflow of gastric or duodenal content that has passed the lower esophageal sphincter into the esophagus without belching or vomiting. So the patient didn't vomit or belched, but suddenly the gastric acid is climbing to the is climbing up. Okay, because the acid content in the stomach is very hard. Um, The acid content, the stomach is very acidic. The pH is, I think, 2 or so. Yeah. So it's very, very acidic. The pH in the stomach is very, very acidic. So when it climbs up, that kind of burning sensation, you tend to have a retrosternal burning sensation. So please, you didn't tell us about the long use of omeprazole. Yeah, so that it was actually a question. I wanted you people to tell me the side effects of the long use of omeprazole. The side effects when you use omeprazole for a very long time, it has a side effect. A side effect. So I wanted you people to type it in the comment section. So if you know it, you type it into the comment section. I actually have forgotten. I have forgotten. But if you use omeprazole for a very long time, it has a side effect. It's not life threatening though, but I mean it has a side effect here. Okay, um so with the GERD, we have two type of GERD. Already I've explained that GERD is when there's what a reflux. Already a reflux. So it's when the acid content in the stomach moves up. Right now, if you have GERD, you have to rule out other possible causes of retrosternal chest pain. And when we talk about retrosternal chest pain, we are looking at pericarditis, we are looking at uh, tip of the jaw, tip of the shoulders and the jaw. Your friend is saying uh, angina pectoris. You are ruling out angina. You are ruling out pericarditis. You are ruling out pancreatitis. You are ruling out how do you call it? Costochondritis. Costochondritis is when there's a slight break in the sternum or in the costo. You see, the sternum, there's something that where the ribs are attached to the sternum, though. We call it the So when there's a slight crack over there, the person that there's a condition called the costochondritis. So all those people, they also come with chest pain. So mostly people get costochondritis when they lift a heavy object. So they'll tell you they lifted something heavy and then they heard a sound in their chest, crack. So they will also come and tell you they have chest pain. And then we have the pericarditis. It means the heart is somewhere here. So since it is somewhere here, it is also occupying the same space over here. Okay. And so when the pericardial part of the heart is also inflamed, the patients can also experience retrosternal chest pain and then some level of pain at the back. So it's up to you to be able to figure out what it is. So with the pericarditis, I think it's part of the Becky's triad. Look later on, I'll look for Becky's triad, and then I'll explain it to you. So with Becky's triad, there's cardiac tamponade. I mean, if you know it, you can put it in the comment section. I've forgotten all those things. So yeah. Okay. So when you have a case like this, you have to rule out angina, retrosternal chest pain. They come and tell you they have chest pain. You have to rule out angina, and that's the most important thing. Then you have to also rule out myocardial infarction. Just the myocardial infarction, it's like a band on the chest. So they'll tell you they're having heaviness on the chest. That one is different from angina. Angina, they'll tell you it radiates to the neck. There's a pain that radiates to the neck and the jaw and the tip of the shoulders. It's either precipitated by doing something, maybe sweeping or something, maybe doing hard work. So that is called a stable angina. But when, let's say, the person is sitting down and is not doing anything, but suddenly is having there's a pain that radiates to the jaw and the neck and the tip of the shoulder, that is an unstable angina. Okay. But when the patient maybe does something giddy giddy, then he starts experiencing that kind of symptom. That is called stable angina. But when the patient is at rest, he's not doing anything, but suddenly he's also experiencing the same thing. That is called an unstable angina. So the question you can also ask, do you feel the pain more when you are at rest or when you are doing something? That is also another way to rule out angina. But I cannot be asking a small child such a question because they are less likely to develop to have such symptoms, even though in this health profession anything is possible. But yeah, so with the GERD or GORD, the British call it GORD, but in the Americans call it GERD. It's because of the spelling. With the US people, the esophagus is OE something. By US, it is esophagus. It's ESO something. Uh, so in US, it is GERD. In British, they call it GORD. That's GORD. Uh-huh. Okay. So GERD is usually classified into two types. We have the non-erosive GERD and then the erosive GERD. So erosion from class 2, the washing away of the topsoil, is the same. You bring the same application here. So when there is an erosion of the surface of the mucus, mucosal surface of the esophagus, that is um, that is what we call the erosive. And then when the mucosal surfaces of the esophagus is intact, but the patient is experiencing all these things, we call it the non-erosive GERD. And how can you diagnose this? You can only diagnose this when you do the endoscopy. And endoscopy in Ghana is expensive. It's over 1,000 cedis. So, but it is good because it is a gold standard and it is the only way to find out if there is esophageal stricture, that is um, thinning of the esophagus. So because of that, food cannot even pass through. Ah, that is one. Okay. So with the GERD, we have the erosive and non-erosive. You can end up having erosive GERD due to um, abuse of NSAIDs. So those who have NSAIDs induced ulcer or NSAIDs induced GERD or erosive esophageal reflux disease. There are people who usually have back pain. If you study the trend, they have some pain somewhere. So because of the pain, they tend to take medication for the pain. Maybe they have arthritis of the leg. So they'll be taking painkiller all the time. And then they'll end up having erosive uh, mucosal lining. Okay. So all those things we should take note. And if you fail to treat the GERD, okay, if you fail to treat GERD, it will lead to esophagitis. Esophagitis is simply the inflammation of the esophagus. It may end up having some little infection, inflammation of the esophagus. If you have a patient who presents with esophageal candidiasis or candidiasis of the mouth, is likely to have candida of the esophagus. And such people, you need to do a retro screen to rule out HIV. It's very important. So, same case scenario, MDC can give the same question, but they can add something small. Oral ulcer, patient with oral ulcer or oral candida infection presenting with throat, or they'll tell you painful swallowing. Okay, so with that question like this, no, they are telling you that the condition is down the esophagus, it's within the esophagus. So you have to add endoscopy as part of your investigation. Very important. And then you have to add retro screen as part of your investigation. If you don't do that, then you are in trouble. You can also do swab for culture and sensitivity, very important. So if you don't do that, you yourself, you know that you didn't do a good job, because someone comes with candida infection in the mouth, you didn't do, or an oral trash in the mouth affecting the ability to swallow. You didn't do retro screen. You didn't do what? Uh, I mean, retro screen. You didn't even do RBS to be sure if the person is not a diabetic whose immune system is now low due to the diabetes. You didn't do that. You didn't do an endoscopy to see where the extent of the damage, one yet. So when that thing happens, you can have it can lead to adenocarcinoma. So you realize it's just something small, but it will end up becoming cancerous. Okay, so if you didn't treat the GERD very well, it will lead to esophagitis, it can lead to ulceration of the esophagus, and it can lead to adenocarcinoma. Okay, so what are the causes of GERD? Obesity. Okay, so obesity is more like a risk factor. Okay, it's not a main cause. And then we have hiatal hernia. I'm sure by now we all know hiatal hernia. If you don't know, you can just let me know. I'll let you know. So okay, hiatal hernia is just a form of hernia that involves the stomach. So the stomach tend to um the stomach will now it becomes like a wedged shape, like an hourglass, where there's some at the top and some at the down, and then the esophagus too is on the top. I don't know how to even describe it to you. It becomes like beans. No, no, not beans. You see, when you buy the beans, the cooked ones with the shell on, I don't even know how to explain it. Like an hourglass, yeah. An hourglass is the main. It's a very distinctive way to explain. So it becomes like more like an hourglass or a dumbbell shape. It becomes like this. The stomach becomes like this. Okay. Uh-huh. That's how it becomes. Okay. So hiatal hernia is also one of the causes of GERD. Also, we have increased abdominal pressure due to pregnancy. So when you have increased abdominal pressure due to pregnancy, anything that causes increase in abdominal pressure, you can have GERD. And then prolonged use of NG tube, nasogastric tube, prolonged, especially stroke patients and all those things, they can end up having GERD. And then we have agents that decreases the lower esophageal sphincter pressure. So we have many things that decreases the lower esophageal pressure. Okay, and those things are usually anticholinergics. When you're looking at anticholinergics, you are looking at what again? Cholinergic properties is what? Salivation, lacrimation, urination, defecation. These are the four cholinergic properties. Salivation, lacrimation, urination, defecation. So properties. Okay, so when you look at anticholinergics, they don't allow tone. They don't allow you to gain tone. They allow you to rest. So and those things are usually diazepam, the use of Buscopan, that's hyoscine butyl bromide. We have propantylene bromide, and then we have morphine. All those things are anticholinergics. Petidine and then calcium channel blockers. All those things are part. So children with chronic neurological diseases also, especially GERD, they also develop cerebral palsy. They also experience GERD a lot, and then those with Down syndrome also. So what are some of the symptoms of GERD? They tell you they have heartburns, especially when they do vigorous exercises or when they bend down. So they'll tell you when they are sweeping, they start developing some heartburns. So that is GERD. But you still have to rule out the angina. Okay, especially when the person is middle aged or not too young, you have to rule out angina. Okay, So dyspepsia, that's abdominal discomfort, early satiety. Early satiety also is not only a sign of ulcer or GERD, it's also a sign of chronic liver disease. It's also a very good sign of chronic liver disease. Early satiety. They eat small and they tell you they are satisfied. It's also a sign of a liver condition. And then retrosternal or epigastric pain that mimics, okay, so retrosternal or epigastric pain that mimics angina pectoris, and then by radiating to the neck or the jaw or the arm. So those are some of the things. It gets worse when you bend down. So when you tell them, you have to tell you can ask them, does it get worse when you bend down? They'll say yes. Then you know that, oh no, this one is not angina. And then most of the times they don't want to eat, and then some of them have it is possible. It can lead to aspiration pneumonia, especially when oh, why is the internet disconnecting like that? Okay. So basically, it is almost the same thing as diagnosing peptic ulcer disease. With the investigation, you need to do the osophagogastroduodenoscopy. You need to do that one. It's the same as upper GI endoscopy. You also can do an ultrasound, temperature, pulse, BP, all those things, they help you to rule out the conditions. It's very important. Okay. Okay. So in cases like this, you can do barium swallowing with fluoroscopy, and then you can do X-ray to exclude all those things I'm talking about. Pericarditis, you can do chest X-ray to exclude all those things. Uh-huh. So non-pharmacological management. So when it is MDC time, they say, oh, how will you manage this patient? You can say elevate the head to about 30 degrees, avoid sleeping in three. Okay, so no, these are not direct management. Too large angina. So you have to start. You understand all those things is very important. And then so to avoid sleeping within 3 hours after eating. We are telling the patient to avoid overeating and heavy meals eating before bedtime. We are telling patients to avoid food that aggravates symptoms. Sometimes they know this food will kill them, but they will still want to eat. You tell patients to avoid NSAIDs, very important. You tell patients to avoid smoking. You encourage them to have moderate exercises so that they will not have a trigger. And then you tell them not to wear corsets. Corset also research has proven that wearing corset or waist strainers are also causes of GERD. So let's look at the pharmacological treatment. With that one, we are looking at magnesium trisiliciate. We're looking at antacids such as aluminum hydroxide or calcium alginate. I have never seen calcium alginate before. So if you've used it, you can let me know. You can use cimetidine and cimeticone. Those ones also have their doses. Omeprazole, rabiprazole. Well, I only know of omeprazole and the rest. Okay, so for severe erosive GERD with bloating, you can use metoclopramide or domperidone. Domperidone is also very good. So what are the classic referral criteria? Why would you refer a patient with peptic ulcer with GERD? You refer cases when the patient is not responding to the measures you have recommended. Okay, with all if putting all these measures in place, but the patient is not getting better, that is when you refer the patient. Okay, we are moving to pain originated from the esophagus. Okay, just a moment. So the next topic is pain originating from the esophagus. So esophageal pain is usually burning in character, and it tends to be localized behind the sternum. So that one too is retrosternal. Esophageal pain may be associated with difficulty in swallowing, dysphagia, dysphagia to water, or dysphagia to water suggests achalasia or achalasia. So that one is when there is lack of nerve supply. Okay, lack of nerve supply to the esophagus, uh-huh, or decreased nerve supply to the esophagus. So when the patient has, they tell you that they feel pain when they swallow water. Okay, when they swallow water, they feel pain. That is likely to be what? Achalasia. And then when they feel pain, when they swallow solid food or anything, it suggests mechanical obstruction. And mechanical obstruction from our previous um, constipation class, we realized that mechanical obstruction could be tumor, it could be anything else. It could be hernia, it could be a lot. So you apply the same thing here. So if it is solid, you are looking at mechanical obstruction, such as tumor, anything carcinoma. We are also looking at how do you call it, hernia or anything else. It's possible. Okay, so there can even be a mass over there obstructing way, a non-malignant, a benign tumor over there. Okay, so so I think they've even listed them here. So while that's okay, so if the patient's painful swallowing of water is achalasia, but when it is not water, it suggests mechanical obstruction, either by tumor, by a stricture, or by anything. There are many causes. Okay. So what are some of the causes? We are looking at irritation of the esophageal mucosa by reflex of the acid content, and we are looking at um, uh, esophageal candidiasis. I've already explained this. So esophageal candidiasis, all those things you need to consider. Looking at hiatal hernia, achalasia, spasm of the esophagus, and then the muscles in response to obstruction. So I don't know if whether you've tried this before. Let's say you saw food, you were so hungry, so you didn't even drink water to start eating. So you just took the food, swallowed the big one. You realize that your esophagus will be churning, it will constrict all of a sudden because it wasn't ready to, you're supposed to start eating bits by bit. Maybe I don't know what, maybe I'm the only one who experienced this because I like food. But usually that is what happens. There's usually spasm. And then we have esophageal tumor. All those things are the likely cause of mechanical obstruction in the esophagus. And then candidiasis, esophageal candidiasis is very important. It's one of the major causes. Also, when you're doing that, you have to rule out cancer, throat cancer, being caused by human papilloma virus. Uh-huh. Especially those who practice oral sex, okay, on women, they are likely to have uh, human papilloma virus in the throat. Okay. Also, we can have syphilitic ulcers in the throat. Um, Treponema pallidum is is a normal flora in the oral cavity. That is what research has proven. But sometimes, they can lose their chains and become, bad, and cause more harm than good. Yeah. So, what are some of the signs? So usually there is none. So usually it's almost dysphagia that they complain about. Okay, and then um, severe weight loss because they are unable to eat. Any patient that tells you that they have weight loss, you have to think about cancer, a tumor somewhere. You have to think about maybe malnutrition. You also have to think about gastric cancer. You have to think of retro retroviral infection. You can also think about a type of diabetes. I think type 1 diabetes, right? Yeah, type 1 diabetes, low production of insulin. Yeah. Um okay, so with the investigation, that one too is barium. It's just the same thing, upper GI endoscopy and the rest. It's just the same thing. So the treatment plan is to relieve pain and then to avoid foodstuffs that will aggravate the pain. So that one to the treatment plan, omeprazole, isomeprazole. You are looking at magnesium trisilicate. You can, if it is esophageal candidiasis, you can use nystatin. You can do nystatin, oral nystatin, um, oral nystatin, 400,000 or 600,000 units, 6 hourly for 7 days. Oral nystatin. So the nystatin, swish in mouth for several minutes and then you swallow. So the oral nystatin, it will be in your mouth for some time before you swallow. For esophageal candidiasis, okay, you do 400 to 600 units, 6 hourly. So 400 to 600 units, QID for 7 days. Or you can do oral fluconazole, that's 200 milligrams start, and then 100 milligram daily for 14 days. But in Ghana, oral fluconazole is 150 milligrams. So I don't know what they are talking about here. So, ladies and gentlemen, we've come to the end of the discussion. Already, I've told you people that if there is any throat pain, not throat pain, pain in dysphagia, okay, once there's dysphagia, you need to do more thorough investigation to find out the cause of the dysphagia. For all you know, it might be candidiasis, it might be a tumor. So whatever you find there, you treat it as such, or you refer for further management. I've come to the end of today's discussion. If you have any question, kindly feel free to drop it in the comment section, and I'll be very glad to assist you. Thank you so much for being with me. Bye.